Hello, my name is Victor Perez, and I'm going to be presenting hemangioblastomas. And this is my second rotation for neurosurgery. So let's start off with the initial. So, I met my patient on August 7th, 2025 at 3:40 p.m. They're 61-year-old white male. Source is self and reliable, and their chief complaint was worsening headaches for 11 months. So HPI, 61-year-old male transferred from Mount Sinai West for acute hydrocephalus. They complained of headache that began in September of 2024, which progressively worsened and started to be accompanied by gradual onset of imbalance. Around 1 month ago, patient noted a new right facial droop. MRI was done on July 11th, which showed a cerebral hemangioma with communicating hydrocephalus, and elective craniotomy was scheduled for August 7th. Then on August 1st, he developed acute worsening of headaches, imbalance, and new nausea, vomiting, prompting presentation to Mount Sinai, where imaging confirmed an acute hydrocephalus. He was then transferred to Lenox Hills for further management and was currently reporting only mild headaches, denies nausea, vision changes, shortness of breath, weakness, or numbness. And then MRI was repeated, now showing a hemangioblastoma. And he had a chronic right arm weakness present from prior shoulder injury. So now we'll be talking about the medical history. So past medical history includes hypertension, hyperlipidemia, benign prostate hyperplasia, and nasal polyps. Surgical history, none were reported. Medication, so he's on atorvastatin 10 milligrams oral at bedtime. Bisoconazole 5 milligrams oral PRN. He's on erythromycin ointment, one application to the left eye at bedtime. He's on losartan 100 milligrams oral daily, pantoprazole 40 milligrams PRN, polyethylene glycol 17 grams oral daily, and Senna 2 tablets oral at bedtime. And he has no known allergies. Now, social history, he lives at home with their wife. Patient is functionally independent at home, or was functionally independent at home, but now requires physical therapy with ADLs. He is able to ambulate with assistance, and patient denies any illicit drug use, alcohol, or nicotine. So now we'll do the review of systems. So general, no weight changes, no fever, no chills, overall feeling okay. HEENT, he complains of mild headaches, states they have double vision, denies congestion, rhinorrhea, or sore throat. Respiratory, no cough or wheezing, no shortness of breath. Cardiovascular, no chest pain, no palpitation, no discomfort when walking. GI, he's presenting with nausea and vomiting, but denies abdominal pain, diarrhea, or changes in appetite. MSK, he does have weakness to the right arm, but no myalgia, no joint pain, no back pain. Neurologic, he has mild dizziness, lightheadedness, but no numbness. And then psych denies depression, anxiety, memory loss. Endocrine denies hot or cold intolerance, sweating, polyuria, or polydipsia. Now physical exams, vitals, temperature was 97.9 Fahrenheit, heart rate 75, blood pressure was 136/73, respiration was 18, SpO2 was 95 on room air. Journal, he's well appearing, well nourished, and no apparent distress. When doing the HENT physical exam, we do notice left eye 4 millimeters and bristly reactive, while the right eye is 2 millimeters and bristly reactive. He does have now a left horizontal gaze palsy, and he has positive diplopia. Unable to fully close left eye. He has no conjunctival or scleral injections, and it's non-icterous. He's normocephalic, atraumatic, or mucosa with moist membrane. Now the thorax and lungs. Neck was supple, no mass, lungs clear to auscultation bilaterally, no rails or wheezes, symmetrical chest rises. Heart and vascular, he has a regular rate and rhythm, no murmurs, no rubs or gallops. Abdominal, it's soft, non-tender, non-distended, and no hepatosplenomegaly. GU, he has no dysuria, hematuria, and no flank pain. Um, Extremities, they're warm and well perfused, no edema. Lymph, no cervical, submandibular, supraclavicular, axillary, or inguinal lymphadenopathy. Neuro, he's ANO to person, place, and date and time. He opens his eyes spontaneously. He's dysarthric in speech. He does follow commands. He moves all extremities spontaneously. He has a 5 out of 5 strength throughout all extremities with right upper extremity mild tremor. Sensation intact in upper and lower extremities bilaterally to light touch. He does have a right tongue deviation, and it's positive for dysmetria bilaterally and positive for left facial. Now the workup we did a CBC, which were within normal limits. BMP also, LFTs, type and screen. He had an ABO grouping of A, RH factor negative, antibody screen negative. So the MRI from July shows focal area of increased density, calcification, and minimal significant pressure surrounding the brain, absence of prominent edema, and cerebral hemangioma with communicating hydrocephalus. Repeat MRI with stereotactic with and without IV contrast on 8-4 showed a large posterior fossa mass appears to arise from the cerebellar vermis extending into the fourth ventricle with cystic and solid components, most likely representing hemangioblastoma. There is resultant hydrocephalus, and images were available for surgical guidance. So now assessment, 61-year-old male initially with prior images showing cerebellar hemangioma and communicating hydrocephalus, now presenting with acute worsening of headache, imbalance, and nausea and vomiting. MRI brain stereotactic with and without contrast images repeated and shows large posterior fossa mass arising from the cerebellar vermis, extending into the fourth ventricle, leading to suspicion of hemangioblastoma resulting in hydrocephalus. Neurological exam notable for mild right facial droop for 1 month duration and chronic right upper extremity weakness from prior injury. He's currently stable and reports only mild headaches. Clinical presentation suggests hemangioblastoma due to given images and location of the tumor. Now the plan. So we're going to be doing neuromonitoring. So we admitted the patient to the neurosurgical service, and he's in neuro ICU with Q1 to 2 Q1 neuro checks. We're monitoring for signs of increased intracranial pressure, worsening headaches, nausea, vomiting, altered mental status. For the ICP management, head is elevated at 30 degrees. We're going to maintain normal natremia, normal volemia. He started on dexamethasone for peritumoral edema, PRN, mannitol, or hypertonic saline if acute ICPs do rise or are suspected. Surgical intervention will proceed with planned posterior fossa craniotomy for tumor resection, obtained images through stereotactic navigation, which will be available, and possible EVD placement pre or intra-op for CSF diversion, depending on intraoperative findings. Pre-op workup with CBC, BMP, repeat type and screen, coagulation profiles, and anesthesia evaluation. Post-op considerations, continue close neuromonitoring, post-op MRI of brain and orbits to assess extent of resection, and then also supportive care, which is pain and nausea control, bowel regimen to prevent straining, which would increase ICPs, and DVT prophylaxis while he stays in the hospital. So now we'll get to the hemangioblastoma. So epidemiology, hemangioblastomas are uncommon, typically occurring in young to middle-aged adults, more frequently seen in men rather than women. They're again most commonly found in the cerebellum or spinal cord, and most hemangioblastomas are sporadic, but a significant portion are associated with von Hippel-Lindau disease, VHL. These tumors are considered rare and typically account only for 1 to 2.5% of all intracranial tumors. Etiology and risk factors. So VHL disease is an inherited condition caused by mutation in the VHL gene, a tumor suppressor gene. Individuals with VHL disease are at significantly increased risk of developing multiple hemangioblastomas, as well as other tumor cysts in various organs. So sporadic hemangiomas, again, associated with, um, these are the majority of hemangioblastomas occur sporadically, meaning they are not associated with VHL disease or any other genetic mutation. In these cases, the cause is often unknown. Family history. So if you do have family history, that increases your risk, especially if VHL disease is present in the family. Other risk factors, again, while VHL and sporadic occurrence are the main factors, other factors like polycythemia or pancreatic cyst have been linked to hemangioblastoma development. Now the patho. So the patho is still unknown, but there are theories. So hemangioblastomas are benign, highly vascular tumors of the central nervous system, often associated with cyst. Their patho centers around the inactivation of VHL tumor suppressor gene, which leads to increased production of growth factors and subsequent tumor development. So what happens when the VHL gene is inactivated? So the VHL inactivation strongly linked to mutations or deletion located on chromosome 3. These genes act as a tumor suppressor, regulating cell growth and division. So then it can lead to hypoxia-induced factor pathway, which is where the VHL protein is involved in the degradation of IHF, which is hypoxia-inducible factors, and the inactivation of PVHL leads to the stabilization and accumulation of HIF, mimicking a state of hypoxia, low oxygen. So pretty much what this is saying is that um, the the VHL protein degrades HIF. So if you have an inactivation of the VHL, then you don't have enough proteins inhibiting the HIF. So then HIF are transcription factors that promote the expression of various genes. This includes encoding for growth factors like VEGF, erythropoietin, and platelet-derived growth factors. So these growth factors drive the abnormal proliferation of blood vessels and stromal cells characterized as hemangioblastomas, meaning that when there's an accumulation of HIF, they encode for all these growth factors, which then can lead to proliferation of this tumor. And then cyst formation, the precise mechanism of cyst formation in hemangioblastomas aren't fully understood, but it's thought to be linked to the increased production of erythropoietin by the tumor cells. So clinical manifestation, typically typical symptoms are headaches, nausea, vomiting, and signs of increased cranial pressure. If it's a spinal hemangioblastoma, usually there's pain, which is localized to the back or neck, depending on the location. Motor weakness, progressive weakness in the arms or legs, potentially leading to paralysis. Sensory disturbances like numbness, tingling, or loss of sensation in specific areas, and bowel and bladder dysfunction, incontinence, or difficulty with urination or defecation. Cerebellar hemangioblastomas, you can have ataxia, which is lack of muscle coordination leading to unsteady gait and difficulty with fine movements. Dysmetria, inability to accurately judge distance, resulting in overshooting or undershooting when reaching for objects, and intracranial pressure. So this just means increased pressure within the skull due to tumor growth and associated hydrocephalus, causing headaches, nausea, and vomiting. So then the typical workup for this is MRI, which is the primary diagnostic tool, which provides detailed images of the brain and the spine. CT can also be used if MRI isn't available. Spinal angiography if spinal hemangioblastoma is suspected, and retinal exam if VHL syndrome is suspected. Retinal exam should be done annually to screen for retinal hemangioblastoma. Another workup considers genetic testing, VHL gene mutation analysis if VHL is suspected. Then genetic testing is crucial for this. And then clinical evaluation, so neurological exam, assessing the patient's symptoms, neurological deficits, which can help determine location and extent of the tumor. So management, typically for these rare cases, it's surgical resection. So you do microsurgical resection as the preferred treatment, especially if there are neurological issues. The goal is to completely remove the tumor while preserving the surrounding healthy tissue. And the technique is they use a microscope and specialized instrument to perform the surgery with precision. Another option is radiation therapy. So, stereotactic radiosurgery. This technique delivers targeted radiation to the tumor, often used when surgery is not an option or residual/recurrent tumors. Mechanism: radiation aims to stop blood flow to the tumor, causing it to shrink over time. And the effectiveness may be more effective for small tumors without a cystic component. Now, here is what they usually do. So they do a right craniotomy for removal of tumors. So what they do is they shave the hair from the head to mark the incision site, and then the scalp fold is reflected, meaning pulled off, and then holes are drilled into the skull to make an opening, which is called the craniotomy. Then the bone flap is removed, tumor is exposed. The tumor is then removed and bleeding is controlled. The bone flap that was replaced and secured with plates and screws, and then the skin incision is closed with sutures and staples. So this is what you would see in the OR if you do scrub into the case. And now complications. So complications for hemangioblastomas include increased cranial pressures due to the obstruction of flow of the CSF, which can lead to hydrocephalus and can manifest as severe headaches, nausea, vomiting, and vision changes. Neurological deficits. So depending on the location, these tumors can compress or damage nearby nerves and brain tissue, causing various problems like cerebellar dysfunction, brainstem dysfunction, or spinal cord dysfunction. Hemorrhage, while this is less common, can bleed potentially causing intracerebral hemorrhage, which can be life-threatening. And post-operative complication include CSF leak, hydrocephalus, edema, and infection. And now emerging therapies. These include anti-angiogenic therapies, drugs like bevacizumab, which target blood vessel growth. This is currently being explored and can eventually be a potential treatment option. Targeted therapies, so medications like belzutifan, MK6482, a HIF2 alpha inhibitor, which show promise in treating VHL-related hemangioblastomas. And then there is immunotherapy, which is currently being investigated as potential strategy treatment. And these are my references. And yeah, that's hemangioblastomas.